It's time to treat fluids as drugs. Here are my disclosures, and my biggest bias being the co-founder of the World Society Abdominal Compartment Center, which is now known as the Abdominal Compartment Society. These are my disclosures. I consult for Baxter, which is the sponsor of the session. My lecture today will be about breaking bad habits. And it seems, especially with the recent recommendations of the European Medicine Agency confirming the PRAC recommendation to suspend starch infusions, it's like a battle between good and evil. So I would like to present to you the case of critical care Northampton from my good friend Johnny Wilkinson, where they performed a survey amongst surgeons and internists, and the results were devastating. Because many patients were dehydrated or fluid overloaded, so they were on either CVVH for AKI or for fluid overload. So what did the docs know about IV fluids? So let's have a look. On the questions, what is total body water, what is the intravascular volume and the fluid and sodium potassium requirements, results were devastating. Only 8 to 40% of answers were correct. And on the question, what did they know about the composition of different fluids, again, the results were 0 to 40%. So you are sacked. And this is not fake news. So what did they do in Northampton? So they start with a program, the three-pronged attack on IV fluid safety with education, changing practice, and increase awareness. They also did a clinical audit of twice 60 cases. They looked cases from internal medicine, and they found out that the daily sodium needs were exceeded about 943%. And the daily potassium needs, they were not covered, reaching only 60%. So did the surgeons do any better? So they exceeded sodium needs with 378%, and they did not deliver daily potassium needs. So what were the most prescribed maintenance fluids in Northampton? And were there any differences between internists and surgeons? So it seems that internists favored saline in 64%, where surgeons favored Hartmann's solution in 58%. Inappropriate fluid prescription was present in 32.6% of internal medicine and 10.3% of surgeons. So definitions for inappropriate fluid prescription was a high and rising sodium above 145 and still prescribing saline, or low and falling below 135 and prescribing glucose, or a high and rising potassium with the cutoffs as you can see there. Were there any lab testings, urea and electrolytes, on the same day of the fluid prescription? Only in 48 of cases of internal medicine and 37.5% of surgery. So do we do any better in our university hospital in Brussels? So we checked with the pharmacy about our consumption over the past 2 years, and the most prescribed infusion was normal saline. So we started a survey in 118 doctors, and the results were devastating as well. Only 40% was the score. Only 75% knew the glucose content of PlasmaLyte, 54% the sodium content of glucium, of saline, 43% the sodium content of glucium, 40% took into account unintended IV fluid intake, like from drugs and antibiotics. Only 25% knew how much you give as a fluid bolus. So we were sacked as well. So that's why we should stop here and start things over and look at fluids as drugs, dealing with the 4 questions, the 4 indications, the 4 phases, and the 4 Ds. The 4 questions we need to ask is first, when to start IV fluids, because the best fluid is probably the one that has not been given to the patient unnecessary. Then comes the question, when to stop fluids. Third question is when to start fluid removal, because some patients may need a little help. And of course, when we are deresuscitating, we must avoid hypoperfusion. So the final question is when to stop removal. There are only 4 indications to give fluids. It could be either resuscitation, for maintenance, replacement, or nutrition. It's often overlooked. So I would like now to focus on the 4 Ds. So it's on the drug, the dose, the duration, the escalation. So what, how much, how long, and when. Treat fluid as drugs. It's the type of fluid. Therapy should be appropriate. We may need to combine fluids and as well look at the timing. But in respect, I would like to present you some data of our own trial with Dr. Van Regenmortel as first author, published in the BGA last year. The MihMoSa trial was in healthy volunteers where we compared isotonic versus hypertonic fluids. So the isotonic fluid was based on normal saline. The hypertonic solution was ready from the shelf. So the results were that the hypertonic maintenance solution resulted in a better urine output, and the hypertonic solution resulted in a less positive fluid balance. Of course, the hypertonic solution kept sodium normal as well as chloride as compared to the isotonic solution containing normal saline. Because we have to realize that when you give glucose, 1 liter, after 1 hour, only 10% will remain intravascularly, compared to 25% of a crystalloid and 100% of a colloid. So the dose is equally important as it makes the poison. We must know the dose for a fluid bolus or a fluid challenge. We must cover the daily needs of water, glucose, sodium, potassium. And pharmacokinetics and dynamics, in analogy to antibiotics, are equally important as well. Because we know that as long as we are infusing crystalloids or colloids, there will be a blood volume expansion, because distribution is slow. But if the blood pressure decreases, then crystalloid distribution will stop. So depending on the state of the patient during infusion, distribution will be higher or lower, and that's because of the Starling equation. But not only distribution, also excretion of crystalloid fluids may decrease and will be very slow during anesthesia and surgery. So the duration of our treatment of fluid should be appropriate. We should treat to the response and not to normalize CVP pressure or urine output. We should monitor hypovolemia and hypervolemia and de-escalate whenever possible. So if water is the problem, then deresuscitation may be the solution. And this gives birth to the concept of the 4 phases of fluid therapy. And I must tell that if you ask social media, there is a slight preference for the acronym ROSE over SOSD. ROSE standing for resuscitation after the first hit, organ support optimization after the second hit, which is based on ischemia reperfusion, stabilization of the patient, and then evacuation of the excess fluids, of course avoiding hypoperfusion. Hence the acronym ROSE. So I must tell you that when resuscitation and the blossoming of the rose at the end is just a dry rose, not a dead one. Why is this important? Because anasarca is not just of cosmetic concern. And if you look at studies published taking into account the different phases of fluid therapy, most of the studies were performed after the initial restriction, and only a few ones are dealing with the actual acute phase. On the other hand, few data is published dealing with de-resuscitation. So it's a bit difficult to compare and interpret the literature data. But I hope you're convinced that you need to go for fluid stewardship and introduce the fluid bundle. And as they did in Northampton, they put posters on the wards and installed screensavers. And the effect of introducing the fluid bundle resulted, of course, in a better adherence to the bundle, but less abnormal urea electrolytes and less AKI stage 1, and a less delay between lab results and prescription. So tailor your IV fluids to the patient's needs and go for fluid stewardship. Drug, dose, de-escalation, duration. This will keep us intelligent, not because we think we know everything without questioning, but rather because we question everything we think we know. Just relax. I only have 4 statements left. The first, sending a kind invitation to join us to the International Food Academy Day in Amsterdam later in November. And if you can't wait that long, join us in Dubai for April 5 for a mini IFAD. I would like you to go home with the following messages. Answer the 4 questions, check the 4 indications, consider the 4 Ds, and don't forget the 4 phases and the ROSE concept. Within the 4 Ds of fluid therapy, treat them as drugs with indications, contraindications, adverse effects. Think about the dose, the timing, initial dose, the speed, cumulative dose, the duration. Stop when they're no longer needed or when the patient is not fluid responsive, and de-escalate whenever possible. De-resuscitate in case of fluid overload, as it causes morbidity and mortality. Introduce fluid stewardship now, so you can start tomorrow by taking a snapshot. Check what you use with your pharmacy, perform a survey on the knowledge, and perform a clinical audit on the appropriateness of the fluid prescription. Plan, do, check, act. Set up guidance, teach, and reevaluate. I thank you for your kind attention.